5 or 6 years. Again, all of our topics are kind of go along with the COA and COT study guides. So some of the things that we will talk about might not necessarily be something you use in your clinics every day, but could potentially be on the test if you were taking it. And with supplemental skills today, it's just some of the skills and tests that are a little more uncommon, some very common and some a little more uncommon that we see other than our normal workup with patients. And so I'm going to go through it today. I've got the Q&A opened here, so if you have any questions, just type them into the Q&A, and then I'll try to keep up with that while I'm going along with the talk and answer those questions. We've had really good participation with the questions in all of our tech training talks so far this year, and so keep up the good work there, and oftentimes those questions will lead to a really good discussion even beyond the scope of what we're talking in the presentation. So let me go ahead and get started here, and just a little bit brief. I had ocular anatomy with Dr. Rasmussen here at the very beginning of our tech training, and so just a brief overview again of the main things that we're going to be looking at measuring today: the cornea and the lens, and also looking at the retina, particularly paying attention to some of the spaces within the eye today. The anterior chamber depth, which is the depth of the chamber between the backside of the cornea and the front of the crystalline lens. And we'll also be looking at axial lengths, the length of the eyeball itself, when we're doing particularly calculations for implants. And so let's start off with intraocular lens implant calculations. And in cataract surgery, of course, we're removing the crystalline lens, and when you do that, you take away a significant amount of focusing power from the eye, and then that focusing power then needs to be replaced with an intraocular lens that's then inserted, and they actually leave the outer covering of the natural lens, what we call the capsule. Some people refer to it as a membrane or a capsular bag, and that outer capsule of the lens is left in place with a small opening in the front, and then the implant's placed inside that capsular bag. That capsular bag kind of shrink wraps around the implant as it heals and helps hold the implant in position. And so when we're doing IOL calculations, we have to calculate what power of implant we're going to put in. And we use three main measurements: the curvature of the cornea, the axial length or front to back length of the eye, and the manufacturer's A constant of the lens. What's not required, which some people think we do need to have for IOL calculations, we don't have to have corneal diameter. It is important for helping to estimate the diameter of an anterior segment implant with corneal diameter, but or if we're doing a phakic IOL like a Verisize, which is clipped onto the iris in the front part of the eye, corneal diameter or white-to-white information is important, but not needed for the actual calculation of the IOL itself. And then second is refractive error. Measuring their manifest refraction is typically not needed. I like to always have it because it gives me a lot of important information. Were they myopic? Were they hyperopic? Did they have astigmatism? And it can help me to calculate the target that we're setting dependent upon what their refractive error was prior to surgery, but it's not specifically necessary for calculating the power of the implant. Now, several different ways or skills or tests that we do to measure the axial length are ultrasound and coherence interferometry. Ultrasound would be using sound waves to determine the distance between the structures of the eyes. And sometimes ultrasound is the only way that you can measure the axial length of the eye, because with a very, very dense cataract, other measurements like the lens star may not get a good picture for us. So the first type we have is an applanation A scan, where we're actually applanating an ultrasound tip onto the front of the cornea and measuring the axial length. And because that tip is touching the front part of the cornea, depending on how hard you push on that cornea, that actually can change. That little depth of that at the front can change where the spikes of ultrasound then occur with the measurement. So it can sometimes give you a falsely short axial length, and depending on how much compression you have when you're pressing on the eye, since it's set right onto the cornea. Sometimes alignment may be a little bit difficult to know that you're going straight from the front all the way to the back, and it's very operator dependent. Now, that can be the main reason for power errors when you're calculating an IOL if you're doing applanation A scans. But usually each office, if you're doing applanation, has one person that would do the applanation A scans. And so they're very, very consistent in the amount of pressure that they put on. And by doing it over and over and over again, they can get very, very consistent measurements with an applanation A scan. But to help make it so that we didn't always have to rely on just one person who did it over and over again and stayed real consistent, we went to an immersion A scan, which is basically using a small shell with fluid. And then the A scan is set at a specific distance from the cornea. The cornea is then bathed in the fluid, so the ultrasound can go through the fluid, then hit the cornea and measure our peaks of our cornea and our lens and our retina to get our axial length. And it gives a more true axial length measurement. There's no corneal compression. There's no direct corneal contact lens, so you're not contact to the cornea, so we're not as worried about an abrasion, and less operator dependent, because once you line everything up, you get a very, very accurate measurement. So immersion A scan is something that we use, particularly when we have someone who has a very, very dense cataract and our optical coherence measurements aren't getting a good measurement. Now, we also can use ultrasound as a B scan, and in a B scan, you're actually getting a two-dimensional view of the orbital tissues. This is useful if we're trying to detect orbital tumors posterior to the eye and looking for retinal attachments, particularly in those patients who have a very, very dense cataract. If their cataract is so dense that we can't see the retina in the back part of the eye, then we'll do a B scan on them, which will give us a two-dimensional picture of the back part of the eye and make sure that the retina is not detached before we would go in and do the cataract surgery. It's an ultrasound like you would think of a traditional ultrasound. It's done right through the lid with a little bit of gel, and very, very comfortable for the patient. Now, optical coherence measurements came through when we, some people use the IOL master. There's one type, it's a non-contact, and it uses interferometry, basically scattering of light to measure the distance from the corneal apex to the deep layer of the retina. And it's very, very accurate, within plus or minus 0.02 millimeters or better. Now, I threw this in just as a little bit extra before we talk about the lens star, which is the most common way we do IOL calculations right now, and why it's important that we use that. But there is one way that you can test anterior chamber depth. Sometimes I get the question that I'm wondering about dilating this patient because they have a really, really dense cataract, and I'm wondering if I dilate them, if I'm going to cause the pupil to actually block the flow of fluid and cause their pressure to go way up. And there is an easy flashlight test to help look at the depth of the anterior chamber, even without looking at a slit lamp. And you shine a flashlight from the temporal side near the limbus, and you can use a pen light or a transilluminator. And if the chamber is deep, the light source will cause the whole entire area of the iris to be equally lit, because the light bouncing off of the cornea in a deep enough chamber will light up the whole iris. If you have somebody who has a really, really shallow anterior chamber and you shine it, you'll get a shadow on the far side. And depending on how shallow that is, since the light can't bounce around as much, you'll get a shadow. And then you know that that person has a pretty shallow anterior chamber depth. Just sometimes they'll ask about a flashlight test to test anterior chamber depth, and that's how you would determine that. Now, we also can get anterior chamber depth, which is one of the measurements we use in our calculations. With the Pentacam, orb scans, the IOL Master, a Visante can give us anterior chamber depth, and they can measure this anterior chamber depth, which helps give us more information about where the IOL would be positioned after cataract surgery. In general, a fairly shallow anterior chamber depth would be less than 2.5 millimeters, and a very deep anterior chamber would be greater than 3.5. And with each of those measurements, you do, when we're interpreting them, we do have to make sure we know which ones measure from the corneal epithelium, the front of the cornea, versus measuring from the backside of the cornea, the endothelium. Now, when depending on that measurement that we're measuring the anterior chamber, we'd also want to know what the thickness of the cornea is. And so another supplemental skill that we use is pachymetry. And this is the process of measuring the thickness of the cornea. It's an important measurement, particularly when we're dealing with patients to find out if they're a candidate for refractive surgery like LASIK or PRK. But it's also an important measurement in the early detection of glaucoma and the assessment of patients who have glaucoma. And our average corneal thickness for most of us is around 550 microns. A very thick cornea would be somewhere in the low 600s, and a very thin cornea would be in around 450. We have pachymeters that we can use. Ultrasound pachymetry is really kind of the gold standard. Again, you still, because it's an applanation, you do have to be a little bit careful with applanating the cornea or pressing on the cornea too much, which could give you a slightly thinner reading on that. But it can have an effect when we're measuring intraocular pressure. The thicker the cornea, the higher the IOP would be measured when we're doing a Goldman tonometry or measuring people's pressure. A thinner cornea would tend to measure a lower IOP than what they actually have. And so we can take that pachymetry or corneal thickness to help us see whether we're over or underestimating our IOP based on corneal thickness. So pachymetry becomes an important measurement in these calculations. And then we get to what we currently use, which is the lens star. And this optical coherence device is able to measure a number of different things. It can measure the pachymetry. We can measure lens thickness, the thickness of the actual crystalline lens. It'll give us information about the pupil. It'll give us a keratometry or corneal K readings, which is one of, if you recall, is one of the main measurements that we use for the calculations. It'll give us an axial length. It'll give us an anterior chamber depth, and it'll even give us a white-to-white or diameter of the cornea. And it has standard formulas that are built in. The nice thing about the lens star is that we can use it to calculate or estimate ELP, or effective lens position. So when the cataract surgery is done, the natural crystalline lens itself that has the cataract is very, very thick. And when we put an artificial IOL in, the IOL tends to be very, very thin. So there's a large space there in which the IOL can sit. It can sometimes sit further back. It can sometimes sit further forward in the eye. And small changes in where that lens sits inside that capsular bag, what we call effective lens position, can dramatically affect the power that the eye has after cataract surgery. So if we have a way that we can more effectively estimate where that lens is going to sit in the capsular bag or its effective lens position, then we're going to be more accurate with our calculation. In traditional IOL calculations, excuse me, we use the anterior K readings and axial length. And that gives us a single reference based on an average of where we think the lens will sit. What the lens star uses is it uses different formulas as well as what they call a C constant, which uses anterior chamber depth and lens thickness to help generate an estimation of where the lens will sit or its effective lens position, which can then give us a more accurate measurement of where the power of the implant is going to be based on its, not only its power, but its position in the eye after surgery. I see there's a couple of questions here. I'll go over to the Q&A. One question coming is, when you cannot get through with accurate measurements with the LenStar, would you try the IOL Master before an A scan? I would probably go to an immersion next. Occasionally, you could have the IOL Master get a measurement through a fairly dense cataract that the LenStar doesn't, but usually those two were fairly close in their ability to get through dense cataract. So I probably wouldn't go to a LenStar next. I would probably go to an immersion A scan next. And then second question is, why is it best to do the A scan undilated? Well, when the pupil dilates, it can actually give you a false representation of the anterior chamber depth itself, because the pupil, as it dilates, the iris itself actually moves toward the limbus or out toward the edge of the cornea, but it also moves anteriorly. And so depending on your alignment of your A scan, you may pick up that pupil being a little bit further forward, and that may throw off actually the depth between the cornea and the lens. And so with that dilation, you could have a slightly different anterior chamber depth or lens position. And because we don't walk around dilated all of our lives, I'd want my IOL calculated in an undilated scenario. Question, another question coming is, do you still personalize your A constant, and do you have a formula to do so? You can personalize within the LenStar personal preferences. What we do is analyze our results, and then they're fed back into the calculations. So our results based on the manufacturer's A constant are set, but then each individual surgeon will have their own nomogram based on our results. So we can adjust what our targets are going to be. If we're consistently getting we're consistently getting a half a unit of myopia with the standard calculation, then we can adjust the nomogram for the individual surgeon to account for that based on their techniques and where they most often put their incision. So thanks for the good questions. All right, so let's move on. I don't see any other questions, so we'll move on from IOL calculations and talk a little bit about dry eye and tear film testing and some of the supplemental skills and tests that we do there. Just a quick review of the normal tear film. Three major components to the tear film. We have an anterior lipid layer, which is produced by the meibomian glands. Basically, a oil layer that sits on the surface of the tears to help prevent them from evaporating. Then we have an aqueous layer, which makes up the bulk of the tears produced by the tear glands. We have soluble proteins in them and mucins that are produced in there. There's membrane mucins. And then right on the, we have a mucin layer then right next to the epithelium, which helps adhere the tears to the cornea. So three major components that we have there. And so when we're testing dry eye, we're really looking for the two types of dry eye, which number one would be tear insufficiency or a low tear volume. So it's a quantity issue. And then we have someone who has an evaporative dry eye, which means the quantity of the tears is okay, but because we don't have that lipid layer on the surface, they evaporate too quickly. So it's more of a quality of tear issue rather than a quantity. And for a lot of people who suffer from dry eye, it's a combination of the two. And so we have several tests that we can do: Schirmer's test, tear breakup, some different staining techniques that we use. And so I want to talk a little bit about those. Now, the Schirmer's test is typically the way we do it is anesthetized, and that would determine kind of the basal or baseline tear production. And it's used to determine if the eye is producing enough tears or they have a good quantity of tears. We use it as anesthetized so that we don't have reflex tears, because the paper strips that are placed inside the lower lid for 5 minutes can sometimes cause a reaction. And so, and with topical anesthetic used, greater than 10 millimeters in 5 minutes is considered normal. So here's the Schirmer's test here. Schirmer's test can be divided up into a Schirmer 1 and a Schirmer 2. There's some people vary how they consider all these. The Schirmer 1 is basically doing a Schirmer's test either with or without anesthesia. If you're doing it with a numbing drop, then you're testing for baseline tears because you no longer have reflex tears with the numbing of the eye. And then Schirmer 2 would be without anesthesia. So you're actually measuring both baseline and reflex tearing, because with no anesthesia, you could reflex tear from the tear strips actually being inside the eye. And then Schirmer's 2, a lot of people consider Schirmer's 2 to be complete reflex tearing. That would be, you'd put the Schirmer strips in and then do a nasal stimulation where you get the person to tear. Some people divide out Schirmer's 1 and 2 as with and without anesthesia. But whether it's 1 or 2, just as long as you know what you're trying to measure with the Schirmer's test, whether it be baseline tear production or whether it be baseline plus reflex tear. And there's a couple questions coming in. And which test do you feel is best about dry eyes? I'm going to talk a little bit about all of the tests first, and then I'm going to answer that one, so thanks. And then I'll also, another one is, does any type of surgery to your eyes make your eyes more dry afterwards? And I'm going to hit that one too. So, but let's go through the tests first. So Schirmer's test is one test that we use, and for a lot of us, we have used a lot of Schirmer's in the past, but with the newer tear measurements that we have, we actually can get some good measurements without having to do a Schirmer's, because it's so variable depending on whether the person blinks and how numb the eye is. Sometimes you can get some false positives and false negatives with the Schirmer's test. And all of the tests that I'm talking about, I think, are valuable, but you're always going to go back to the patient's symptoms, what they're experiencing, either whether they're wearing glasses or contact lenses or after surgery. You're really going to go back to their symptoms and then let the testing help direct which way to go. Now, a second test that we'll do is what's called a tear breakup time. And the meibomian glands in the lid produce that lipid or oil layer that helps prevent our tears from evaporating. And anytime that we have a meibomian gland dysfunction, or those meibomian glands get plugged or clogged, then the amount of lipid or oil in the tears will decrease. And when these glands get plugged up like this, the oil just can't be produced and go onto the eye to help prevent the tears from evaporating. And that person would have an evaporative dry eye. One way you can measure for that is a tear breakup time. Measure how quickly the tears are evaporating. When you use the most common dye that we would use, which is fluorescein. And fluorescein will stain the tears, and it'll show up as a yellow or green. And if you have any areas where the epithelium or skin on the surface of the cornea is missing, that will show up as a bright yellow spot. That would be a keratitis. But without any keratitis, the tear film itself will be green. So you can watch the tear film as a person stops blinking, and you can see these little dark areas that appear. Those are all areas where the tears are evaporating. And you can just count out the amount of time. So we'd put in the fluorescein at the slit lamp. We'd have them blink a good 3 times and then hold open for as long as they can, and then measure the time that it takes before we start seeing the first areas of tear layer evaporating show up through the dye. And anything greater than 10 seconds is considered normal. Marginal would be between 5 to 10 seconds, and anything below 5 seconds would be abnormal. And this is one of the more common tests that we use in our research clinical trials to measure for dryness after surgeries. Two other types of diagnostic dye tests that we have are rose bengal and lissamine green. Lissamine green is used in conjunction with fluorescein. It stains any cells that are dead or devitalized, that are dying off. So the fluorescein will show us on the cornea if there are actually cells that are missing or have come off, or if you have somebody who has an abrasion on their cornea, it'll show up as a bright yellow area on the cornea because it's staining where the cells are missing. Lissamine green will stain cells that are either have died or are starting to die, and it works best to see it on the conjunctiva. Rose bengal will stain any area that's unprotected by that mucin layer. And in herpetic corneal infections, like herpes zoster or herpes simplex, the dendrite that forms within the cornea can be stained with rose bengal as well. So a couple other dyes that we use in diagnostic testing. And then I'm going to answer a couple questions here. Let's see, maybe I'll just go through the tear lab and the inflammatory, and then I can make it, then I can answer a couple of the questions that have come through. So, and they might have been put in answered, so I'm going to make sure that I get to all of them here. The most common measurement for dry eye we use in our practice is the tear lab. And basically what the tear lab does is a very quick way to measure tear osmolarity, or the concentration of our tears. And if you have a then that would indicate a dry eye. And it's kind of nice that it gives a number. It'll give a number so anywhere between in the mid to high 200s, you know, like 270, 280, all the way up to 340. I really haven't seen many past 340, but you can see in the bottom here that right around 300 is normal, 300 or below. Anything above 300, typically they'll say that 308 and above would be abnormal. Also, if there was a difference between the two eyes, so if you had 320 in one eye and 300 in the other eye, that usually means that the tear film isn't very stable, so more than likely leading to dry eye. So using osmolarity as a test to test for how severe dry eye is. Last test that we do for the tears themselves is the inflammatory. And when people develop dry eye, the front part of the eye becomes inflamed. Not only the conjunctiva and the lids, but also the glands that produce all of the constituents of our tears. And when those glands become inflamed, they actually produce less. So one way to measure for dry eye is measuring for inflammation. And RPS makes a test called inflammatory. It detects MMP9, which is an inflammatory marker in the tears. And it's elevated in people who have dry eye disease, specifically with inflammation. Another very, very quick test with a sample of tears that gives you a good sensitivity and specificity that can tell us whether inflammation is an issue with this as well. So those are the main tests that we do with the tears. Going back to the question, which is my favorite dry eye test, I kind of like 3 different tests would be my favorite. In other words, if I could have just 3 tests that I could do to test dry eye, I would have fluorescein dye, and I would have a tear lab, and then I would have a slit lamp to look at the glands of the lid. Now, having this next test that we're going to talk about, which is a LipiView, gives me an even better idea of what's happening with those meibomian glands for those patients with evaporative dry eye. So, but if I can look at the glands, if I can get a measure of the osmolarity in the tears, and I can use a common fluorescein dye to see tear breakup time and any dry missing cells on the surface of the cornea, then those three tests would be my favorite three to help me determine what's the best option for that patient. Another question coming in is, how much time should you wait after instilling the proparacaine before performing a Schirmer's? Usually I think anywhere between 2 to 5 minutes is fine. You just want the eye to be numb enough that you're not getting reflex tears. And sometimes you'll put the Schirmer's strips in after about 4 or 5 minutes after you put the numbing drop in, and then they'll just wet the strips all the way to the end, you know, in a minute. Well, then I usually would say, let's give them another numbing drop, wait about 5 minutes, and then re-put another strip in and see, because you're getting some reflex tearing in there as well. Another question is, if the problem is inflammation, how is it treated? Well, typically with an anti-inflammatory, and the two most common anti-inflammatories that we use in dryness are Restasis and Xiidra and the new Cequa. These are eye drops that actually work within the inflammatory cascade to help reduce inflammation, not like a steroid eye drop would, or even a non-steroidal like Ilevro, or like a liquid form of Motrin in the eye, which would be an anti-inflammatory as well. But these can safely be used over time, and there's a lot of people who are on Restasis or Xiidra to help reduce inflammation in the front part of the eye, so that the glands of the eye that produce the components of our tears can produce more. And that anti-inflammatory effect from Xiidra and Restasis also can help with these meibomian glands. It's been shown to help them flow a little bit better as well. But the technology that we use a lot is the LipiView, and it actually gives us a scan of the glands themselves. Now, the LipiView can look at the meibomian glands, and where they're tall, nice and straight white columns like this, these are really good glands in the lid. If these glands, meibomian glands, get plugged or clogged up, then they can atrophy over time. And so here's an example of a gland. There's several glands here that have atrophied. And once that gland has atrophied, it really doesn't grow back. There's some evidence that if you treat this and really work on the lids, that you can get the gland to kind of come back a little bit. So we always want to work to try to help these glands be open and flowing freely. And the exact process of blinking, our two eyelids coming together and the pressure of the lids hitting each other, is what helps these glands extrude this oil that provides this layer or oil slick on the surface so our tears don't evaporate. And so with the LipiView, you can actually measure the glands or image them. It will actually measure the blinks. It will have the person look straight ahead and just blink normally, and it'll tell whether they're giving us a full blink where the lids actually come all the way together, or a partial blink, where a partial blink, or almost like a bat of the eye, won't actually put enough pressure for the glands to open up. So even instructing patients on how to take full blinks can help with these glands evacuating that oil out. And then the LipiView can also measure the thickness of that lipid layer on the surface of the eye. And about 100 nanometers or more would be considered normal, and anything under 100 nanometers would be considered something that would be a low level of mucin layer on the surface of the cornea, and then we would want to look carefully at these meibomian glands. And then, in a way to help get these glands open and flowing, is using both heat and pressure or massage. And so the LipiView instrument can measure these things for us, and then we can do a LipiFlow treatment, which actually involves a cone that's placed over the cornea, and then the lids are placed on top of the cone, and then there's a little piece that sits over the top of it, kind of a roller that heats up the lid, and then the roller rolls back and forth across the glands to help evacuate these out. And it's about a 15-minute procedure, which allows, by heating up these glands and massaging them, to help open these glands. Other types of instruments like the iLux and the tear care also can heat up the lid so that, and then mechanically putting pressure on the glands can help open them up as well, and work very similar. And the success with these is quite good, especially for these people who have glands that are starting to atrophy or are very short, because we don't want to allow these glands to continue to atrophy down to where they have very, very few glands, because then they're in a real tough situation of not possibly being able to get them to come back. And so identifying these things early is very, very good for us. And so we use the LipiFlow quite a bit, and really helps out. In addition to that, people can do home therapy, and you've had lots of patients who've been instructed to do hot compresses and lid massage at home, whether they use a warm wash rag under warm water placed on the lids for 3 to 5 minutes, followed by a little bit of using their finger to massage or press on those glands. Using a fire and ice or brooder mask, a gel mask that can be heated up in the microwave, can help heat those glands up as well. And I have all of the patients that I have that have meibomian gland dysfunction that do LipiFlow, I make sure that they're also doing that home therapy as well. Question comes in, have you had success with the iLux in treating MGD? We don't do the iLux here in Sioux Falls. It's mostly the LipiFlow, but I know in our Alexandria office, Dr. Risved and Dr. Walker up there do a lot of iLux, and they have really, really great results with it. So again, whatever manner you're using, the whole goal is to heat up the meibomian glands so that the oil can flow, and then some type of pressure or compression to help extrude that oil out helps keep these glands healthy. And then going forward, patients doing their home therapy, making sure that they're doing nice full blinks, and that can help a lot to keep these glands open and flowing for a long time. Question comes in, how often do you have to treat with this instrument, and do you have patients treated home with warm compresses and lid massage? So second question, yes, treated home with warm compresses and lid massage. You know, I have some people who do one of the treatments, whether it be LipiFlow and Dr. Walker up in Alexandria probably finds the same thing with the iLux up there, is that if you treat this and the patients do the home therapy, a lot of times they can go a year to 2 years doing very, very well, and some only need one treatment. I have other people who have very significant meibomian gland disease and a lot of glands that have atrophied. Even though they're still doing their home treatment, they still can sometimes have symptoms, and they may be doing one of these in-office treatments every 6 months to a year. So it would vary based on their symptoms and how well they're doing, but typically you're going to get somewhere between 6 months to a year, sometimes longer. All great questions, so thanks for that. And I'm going to pay attention here to our time. We're going about an hour today. I wanted to go through a little bit quickly on some color vision testing. Another one of the supplemental skills that we do in our office here, not all that often, but oftentimes out there you may be doing more color vision testing. And first we want to make sure we got our terms right. It's called a color deficiency, not color blind, meaning seeing no color at all, but more of a color deficiency. And our own Dr. John Berdahl is color deficient, and one of the advantages that he's found is that he can solve a Rubik's Cube every single time. And since I can't hear any of you, I'm assuming you're all laughing, and yes, Dr. Berdahl does know that I'm using that joke. So All right, so in normal color vision, we have a good representation of all the different color spectrum, from short wavelengths to long wavelengths, and a good representation all the way through. The photoreceptors in our retina, we have both rods and cones are what really pick up that color. And we have three types of cones: a long wavelength cone, which would pick up more in the red spectrum. We'd have middle wavelength or green that would pick up, the middle wavelength would be green color. And then we have short wavelength, which would be blue. The rods just pick up light from dark, and so they go kind of across the middle of that spectrum. Well, in the genetics of color deficiency, the defect actually is on, and is, because it's genetic, it falls on the X chromosome. So it's an X-linked inheritance pattern, meaning that in males who are XY, one defective X will result in color blindness or color deficiency. And in females who have two X, they'd have to have two defective X's to be colorblind. So the incidence is much greater in males, all the way up to 1 in 12, but somewhere around 5%. And the amount of color deficiency is variable, some with more and some with less, and then a very, very small percentage of females. So back to our normal color vision. Now, in a type of color deficiency called protanopia, then, which is the absence or a reduction of the long wavelength cones or red spectrum, we get more of a blue, yellow, and green hue to things and a difficulty recognizing red. We can have deuteranopia, which affects the medium cones or green, which then we would get a bluish and yellow and brown tone to things. And then we also can miss the blue wavelength or the short wavelength cones, which would be a tritan or tritanopoly, tritanopia defect. And so these are the different types of classifications of color deficiency. And there's a couple different strategies on how you can test this for patients. The most common is the pseudo-isochromatic test. Most common one we have in our office are the Ishihara color plates. And then there are disc arrangement tests, Farnsworth D15 or the Farnsworth-Munsell 100 hue. And so with these two different ones, there's some advantages and disadvantages. The pseudo-isochromatic plates are quick to perform. You can screen for color deficiencies, but it doesn't necessarily classify which one they have. The disc arrangement tests are designed more to help you determine what type of color deficiency they have, whether it's protan or deutan or tritan. And on the plates themselves, pretty easy. We have some colored numbers or figures. You open up the book, you test each eye independently, and you have to have a certain amount of illumination in the room. And it allows you to determine whether or not the person has a color deficiency. And the plates are presented to the person, and they're asked to tell you whether they see a number on the plate, and then you would record the number that they write down. There are also some pediatric color plates, and there are, for nonverbal patients, there are some shapes where a person can trace the shape on the isochromatic plate. When you're testing these, the first plate, always, everybody can see this, even color deficient people can see the first plate. So that's a control plate. It confirms that they have good enough visual acuity to see, that mentally they're okay, and that they're cooperating. In other words, they're not malingering and trying to fool you. So if someone misses the first test plate and you know that they have good visual acuity and can see at that distance, then you have to consider whether this is a lack of cooperation or malingering. In the scoring, you would just show that they either get nothing, no control, they saw only the control, or the number out of the 14 plates that they saw. If they saw 14 out of 14 or 6 out of 14, and you can score that. So that can help determine whether or not you're dealing with someone who has a color deficiency. The disc arrangement tests are arranged in a transition of hues. And to determine if someone has a mild color deficiency, you have to have a greater number of discs. So The most common one is the Farnsworth D15. You have the person arrange the hues all in a line from starting from the blue all the way up to the red or purple, and then on the underside of them is a number, and then you put the number and show where they went. And if they go skip from like 3 to 15 and 14, that might be in a deutan type color deficiency. But there's just 15 tests there. So in very, very mild types of color deficiency, you may not be able to determine which one of the types of defects they have. They have a computerized test that you can do this as well, and then score that way. If you're really trying to be sensitive for mild color deficiencies, and this is very rarely performed, but you can go to the Farnsworth-Munsell, which is 100 hue. So this is 100 of these all laid out in order, and then you score them the same way, but has a lot more specificity if you're looking for mild ones. So color vision testing can be quick and simple, or it can be complex and time consuming depending on what your goals are, whether you're trying to really get down to the type of color deficiency that a person has, or if you're just trying to determine whether they have a color deficiency and kind of make sure that it's practical for what you're doing. There can be some problems with the optic nerve and the retina that can affect color perception, where a person perceived color normally before, and so doing a color vision test like an Ishihara plates can help you determine if they have lost that ability for their sense of color. And one of the questions, this wasn't a question in the question answer, but sometimes I get this question all the time, which is, do dogs see color? And actually dogs do see color, not just black and white, but they see everything in a hue of yellow, blue, and gray. So everything that they see kind of falls within those three categories of a yellow, blue, and gray color. Whereas human views, we go all the way from red down to the very dark purples. So a couple other tests that we can look at, and some of these come up on the COA and COT tests, so I put them in here. But one that I use occasionally is called a red cap test. And some of these tests that we're going to go over now are just real quick, simple tests that we've all maybe seen or done, but sometimes really thinking about what these tests do can give you a lot of information about what's happening with a patient. You don't need a lot of fancy equipment sometimes to determine if the person's got a problem with their eye. And the red cap test is basically comparing a desaturation of red color perception. So someone who has a macula or optic nerve function problem, they have swelling of their optic nerve, they have a macular issue or something like that, particularly in one eye, and you want to determine how relative that is, a real quick test is to do a red cap test. Now, what I like to do is take like a red cap off of either your phenylephrine or your cyclogel bottle, and then I take and put the transilluminator inside the cap, and that gives you a nice bright red light. And then I have them cover one eye, and I ask them to assess kind of how bright that red is, and then I have them cover their other eye and show it to the other eye. And I have them compare, like, how much is it worth? If this eye is worth $1, what's this eye worth? And if they say 50 cents or a quarter compared to the other eye, then I know that there may be something in that eye which is desaturating the red. So I need to look more carefully at their optic nerve and their macula. Another quick test to do, and people say if you could just do one test on people to determine whether they have a problem or whether they don't have a problem, then the pinhole is the answer. A pinhole will bypass any refractive error that the person needs. So if they have any nearsightedness, myopia, farsightedness, hyperopia, or astigmatism that's not corrected, and you hold a pinhole up and look through it, that will bring the light into such a small ray into the eye that it will bypass any refractive errors. And Or sometimes if there's a corneal opacity or corneal irregularity, or even sometimes certain lens opacities, if you can get the pinhole lined up just right, you can sometimes see around those opacities. So it's a quick way to determine if someone is not seeing well. I don't see very well, either distance or near. You can hold up a pinhole. And if that's just due to a refractive error or needing an add, for example, a bifocal, then putting the pinhole up will then give them clear vision. Then you know that there's nothing wrong with the eye. If their vision is blurry and you hold the pinhole up and things aren't clear through the pinhole, then you've got to investigate more closely, looking at the cornea and the lens and the retina and the optic nerve to figure out why they're not seeing as sharp and clear as they could. So let's see. Couple tests here, one back on dry eye. Exactly how do you know if the dry eye is due to inflammation, and then if the Restasis or Xiidra will be beneficial? Well, a lot of times, if you're doing an inflammadry, that can help you determine if there's an inflammatory component. Oftentimes at the slit lamp and just looking at patients, you can tell there's a low-grade inflammation in the conjunctiva and the lids, and the patient has that itchiness, which you want to make sure you're not confusing with allergies, but they have kind of that inflammatory component along with the dry eye. And a lot of times Restasis and Xiidra will be very beneficial. In fact, a lot of people who use it, probably 75 to 80%, really think it makes a big difference in dry eye, whether it's tear deficient dry eye or whether even in evaporative dry eye, along with the other things we do for the meibomian glands. But I have a percentage of patients who will try Restasis or Xiidra and don't feel like the Restasis or Xiidra does a very good job. And the one thing about the Restasis and the Xiidra is that they do take a while to have their effect, meaning that it can sometimes take 4 to 6 weeks after you start the drop before you really know the full effect of those medications. So some people will be taking them twice a day for a couple weeks and they don't really feel like they got any relief, and maybe they burn a little bit when they put them in, and so they think, I'm just going to stop this because it's not working. And you got to really encourage them to stick it out for a good 4 to 6 weeks to see if it is really part of their dry eye regimen that will help them. Question is, how are the deficiencies scored? So in the tests that we do, the scoring of the deficiencies for the Ishihara color plates, it can give you some inferences based on which number of plates they missed. So on the Ishihara color plates, you can look into the manual and say if they missed this plate, this plate, and this plate, they're more than likely protan. If they missed this plate or this plate, they're more than likely a deutan, but it won't tell you specifically. In order to get specific, you'd have to go to one of the Farnsworth tests, either the D15, and then you can score them on either through the computer or by mapping it out on a paper sheet, and then you can tell whether they're leaning toward protan or deutan. And sometimes even with the Farnsworth D15, you don't have a specific, but you know that they have a color deficiency, and then start to work with them about how they would deal with that and how it would affect their eyes. Another comment, a great idea with the light in the cap, the red cap test. It's a really good test when the patients are telling you things like, things aren't as bright out of one eye versus the other. A red cap test is a really good one. Here's another really good question. Do you have a preference between the two products, Restasis and Xiidra? I don't have a specific preference between the two. I have a lot of patients on both that do very, very well. I've had some patients on Restasis who did okay, and when I switched them over to Xiidra, they did even better. I have some people who used Xiidra and felt like it didn't do much, but when we came back and tried Restasis, they felt like they had more effect. So they both of them work in the same inflammatory cascade, but the Xiidra works a little bit earlier in the cascade compared to Restasis, so they work slightly different. But sometimes it even comes down to personal preference. And some insurance formularies will cover one versus the other, because if your insurance isn't covering it, these medications can be sometimes prohibitively expensive for the patient. So I'm comfortable with either one of them. Both are good medications, and sometimes just comes down to patient preference. So all good questions. Got about 3 minutes left. I'm going to cover a last few here. Dominant eye. We all have a dominant and non-dominant eye, just like we have a dominant hand. Some are less dominant with their eye, just like they are people who are ambidextrous and can use either right or left hand equally well. Some people are not strongly dominant in their eye, but most people have a dominant eye. And one of the best ways to determine dominant eye, I think, is instead of using a card with the hole in it, and then grabbing the card and then pulling it back to your eye, holding it out at arm's length and then pulling it back over one eye or the other. I like the test where you have the patient just put one hand over the other, so they create a small opening between their thumbs and forefingers, and then hold their arms at arm's length down by their knees. Then you slide back about 4 to 6 feet back from them, and then have them raise their hands up and look through that hole at your nose. And so this is somebody looking right at my nose, and then took a picture of them. So I get two ways of feedback of determining the dominant eye. One is I'm looking right at her right eye through the hole. So I know that her right eye is her dominant distance aiming eye. And then second, I'll ask her, if you close your right eye without moving your hands, does my nose go away? And if she closes her right eye and my nose goes away, then she knows that she's looking through her right eye. So we have two ways to confirm that this is a patient who is right eye dominant. Majority of people are same eye dominance as hand dominance. And then there's a few of us who are weird and are right-handed and left eye dominant like I am, that are cross dominant. So let's talk a little bit about a BAT test or brightness acuity test. A couple different ways that we can do these. You can do a BAT test in the room over the person's spectacle correction. This glare testing assesses the patient's vision in the presence of bright light. We use it particularly for cataracts. RK incisions can also reduce vision with the brightness acuity test. But you're testing them on low, medium, and high. Low would be like a brightly lit room, medium would be an outdoor sunlight, and then high would be like sunlight coming off concrete, sand, water, or like an oncoming bright headlight. And those three light settings, if there is any irregularity, lens opacities like a cataract or corneal scarring, then that light will be scattered. And you measure their vision on the acuity chart with their prescription on in the presence of this brightness, and you can see how much their vision reduces if they have any of those things going on. So it's not uncommon that we have people who, with their corrected vision are 20/20 or 20/25, they've got a fairly significant cataract and they're complaining about their vision, but they still can see most of the letters on the 20/20 line with their correction. And then we do a brightness acuity test on them and find that their cataract causes the light to scatter so much that the best they can see is 20/60 or 20/80 on a high setting with the brightness acuity test. So that tells me that their cataract is scattering a lot of light. Our Epic autorefractor can also measure for not only high order aberrations, but you can also do a brightness acuity test on that. That's the one we use most often, but you can do them in the room as well. Last thing, well, actually I'll end it there. If anybody wants to, the slides will be available, but if anybody wants to know about exophthalmometry and using the Hertel exophthalmometer, which is probably the rarest of all the supplemental tests that we do, The slides are on here. I'd be glad to answer questions at any point about that and how it's used. Usually when I'm doing these talks live, I bring the Hertel in and demonstrate it so people can see how we measure for exophthalmos or proptosis in eyes that may have an issue. So if you have any questions, oh, that guy's got all kinds of stuff going on. Thanks so much for tuning in today. Sure appreciate you listening. Hope you picked up a lot. Great questions, and you guys stay safe and stay healthy. Thanks so much.
Thanks, Dr.